Welcome everyone to the August 4th, 2020 COVID-19 clinical rounds special session on transitions of care from acute care to long-term care. My name is Richard Hunt. I'm an emergency physician who serves as senior medical advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer, real-time sharing of COVID-19 critical care challenges and successes. If I'm a clinician caring for COVID patients, the clinicians I want to learn from are those clinicians with the most experience. This is a voluntary public-private collaboration, thanks to the multiple professional organizations who have collaborated. These are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges with other clinicians. Thanks to the National Emerging Special Pathogen Training and Education Center for their support with these rounds. NETEC has webinars that complement these Project ECHO COVID-19 clinical rounds. Thanks to Project ECHO, Dr. Bruce Struminger and his team for the peer-to-peer learning platform we use for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. This Thursday, August 6th, will be emergency department rounds on Hurricane Isaias and COVID-19 response. Our speakers for those rounds will be Dr. Kathy Lehman-Huskamp and Dr. Juan March. For those of you who have been on rounds before, they actually spoke on hurricane preparedness a few weeks ago, and now we're going to have the opportunity to learn about how that actually worked out. Stay tuned for future announcements on rounds. We'll continue to work to identify topics for these peer-to-peer learning rounds that are most timely and helpful to clinicians. For the ECHO clinical rounds we've had to date, we continue to have participants from all states and other countries. We apologize in advance that we're not able to answer all the questions we receive. And for this one, we received 3 pages of questions. We pick out major themes and hope to cover some of those throughout the rounds. Now I'll ask Project ECHO to go over some logistics.
Thanks. Hi, my name is Amanda Dezan. I'm a program specialist with Project ECHO. Just a couple quick things to go over with everybody. Down at the bottom of your screen, you'll see the Q&A function on Zoom. Please use this for any questions or comments you have regarding the presentations or discussions. There's also a chat function. You can use that for any questions regarding technical or logistical issues, and we'll also be using the chat for an upcoming crowdsourcing question. The session is being recorded and attendance is consent to be recorded, so we appreciate that. Presentations from today and all past sessions will be available on our website along with a link to the recording and in follow-up emails. We'll put a link in the chat towards the end of the session to claim CME or CE credits via the University of New Mexico, which is where we're located at Project ECHO. The link is also available in the email announcement that went out this morning from us. And finally, these learning sessions are focused on patient care and health systems and supporting clinicians. So we appreciate everybody keeping them apolitical. A quick note on data usage. We do collect information via registration, participation, the Q&A, chat, comments, and poll responses. And we do share the data with HHS ASPR. However, individual data is kept completely confidential. And they may be used for reports, communications, surveys, etc., everything listed on here. And now I will hand it off to Dr. Mukherjee for a note on NETEC.
Thank you, Amanda. Hi, everybody. This is Vikram. I'm an intensive care physician and I'm representing NETEC here, which is the National Emerging Special Pathogen Training and Education Center. We are really happy to collaborate with Project ECHO and ASPR on this endeavor, and we identify topics that are in much demand and do a deeper dive into such topics. in future webinars. For example, this week we have webinars on supply chain and inventory control. A couple of weeks down, we have anticoagulation webinars and so forth. So a great opportunity to complement what Rick and his team are doing here.
Great, thank you. Another quick note that the AAMC has a clinical
Amanda may have dropped out technically, but I'll pick it up here. Amanda, while you're trying to get back on, what we want to highlight the AAMC's clinical guidance repository, which is available and was shown up there on the screen. Next, we'll go to our crowdsource question, please. So for those of you who have joined us before, you're familiar with these crowdsourcing clinical pearls. We ask each participant who is able to please respond to this clinical crowdsourcing question. We've really picked up some really fascinating and helpful responses in these crowdsourcing chats. So please, if you could, answer the following question. Since COVID-19 began, what has been the best improvement your organization has made in transitions of care between acute care and long-term care? And I already see one has already popped up, the communication. So keep going. We've got like 279, 280 participants. It would be really, really helpful if you can support everyone's learning by answering in the chat on this. So with that, I'd like to go back to the Hollywood Squares for a minute. And if each of the panelists could please unmute yourself and briefly introduce yourself. I'll go around the Hollywood Squares one by one to the panelists to briefly introduce yourself with your name, your title, and affiliation, and then I'll introduce our speakers. So let's start with Manisha. Manisha, please.
Hi, good afternoon, everyone. I'm Manisha Purolakar. I'm Chief of Geriatrics at Hackensack University Medical Center. And I'm today, especially, I'm a chairman for Transition of Care Committee for AMDA. And that's the reason why I'm here as a panelist. Thanks,
Manisha. Christian.
Hi, I'm Christian Bergman. I'm a geriatrician in Richmond, Virginia, associated with VCU. I'm the vice chair of the Transitions of Care Committee for AMDA, the Society for Post-Acute and Long-Term Care Medicine. And I also run our local nursing facility attending service locally here in Richmond. Thank you all.
Thanks, Christian. Vikram, please.
Hi, everybody. My name is Vikram Mukherjee. I'm a pulmonary critical care physician based out of Bellevue Hospital in New York City, where I work as the medical ICU director as well. Thank you for having me.
Thanks. Abby?
Hi, I'm Abigail Vile. I am the lead for the long-term care team on the HHS Healthcare Resilience Working Group.
Thanks, Abby. And Manisha? Oh, Manisha, wait a minute. You were there before. Yes, I'm seeing like a couple of, I'm seeing it double. That's great. No, I'm good.
No, sorry, I think somebody
got it.
Probably because I'm on landline. Yep.
No, yeah, you got to have the backup thing. As a way of background for this particular session, special session on transitions of care, actually weeks ago, Vikram and others, Mark Caridi from Atlanta, presented on the long tail of COVID-19 and some of the challenges, particularly with ARDS. As I've had the privilege to work with Abby Vial with the long-term care group with the healthcare resilience work group at HHS, it was a really important opportunity for us to have these rounds where we actually talk together, both acute care and long-term care. And really, we've had many critical care rounds. This is the first time we've had one where we've joined forces together because this is indeed a group effort, trying to take care of our patients, and really want to extend a warm welcome to our long-term colleagues who joined us today. With that, I'm going to introduce our first speaker, Radu Pastelniku from Pulmonary and Critical Care Medicine at NYU School of Medicine and Associate Director of Bellevue Medical ICU. He is the Assistant Program Director at NYU's Pulmonary Critical Care Fellowship. Radu, welcome back. I really appreciate your continued contribution to the rounds.
Thank you, Rick, and thank you for having me. And it's a pleasure to be here and to speak about this very, very important topic for us, as you've already mentioned. So without ado, I'd like to just start. 1 second, let me just get everything loaded up here. All right. So as you said, right now we want to focus on the next steps of essentially care for these patients with COVID-19 that we've seen. And we want to discuss sort of the transitions of care from acute care to long-term care. And for us here at Bellevue, we've been in an interesting position that we have been now on the tail end of what was our huge peak in March and April. We've had over 1,300 patients with COVID that we've had at Bellevue that we've discharged. Numerous patients, obviously, that have gone through our ICUs as well. And what we've noticed is that there's a very, very wide array of recovery for these patients. The recovery aspect is much longer than typical ICU patients. There's a significant component of post-ICU care syndrome that affects them and also their families. The patients, oftentimes, if they're in the ICU for a prolonged period of time, we've noticed they've become severely deconditioned just because they've been in the ICU for an incredibly long time, much longer than typical ICU patients. Now we're starting to see the tail end of all of this. And now we're starting to understand that actually, you know what, while they were in the ICU, they're incredibly sick. There's also these other complications that can happen once they leave the ICU. We've seen patients sometimes come back with possible complications. We've known that we have, that this is not a one-time disease that we really need to focus on. It's something that has very long impact on their clinical course. And we also have a clinic here where we're seeing a lot of these patients now to sort of understand exactly what happened during their disease process and now in their recovery stage. So we've seen quite a few patients, and it really brought this topic really to light, because what we have to see and what we have to understand is in these patients, once we transition out of the ICU, we have to think about which patients are ideal for this, which patients are typical and which patients are atypical and which patients are going to be better suited for more safe dispo planning. So what we've known is that patients with COVID-19 have a significantly longer ICU course than regular ICU. And the actual data for that is still being collected to see exactly how much longer, but overall we've seen that their ARDS course is much, much longer than typical ARDS patients, for example. Now, once we've seen that patients have significantly improved in the ICU, we have to determine, well, when are they ready to transition out of the ICU? So we use a few variables that are important for us. Namely, we want to make sure the patient's extubated, and we want to make sure that the patient's hemodynamically stable for at least 24 to 48 hours. Now, interestingly, for these patients, tracheostomy becomes very important if they're on a ventilator for a prolonged period of time, especially in the ICU patient population. And there's a lot of debate about the timing of when it would be appropriate for tracheostomy. So some of our colleagues up the street from where we are at Bellevue at NYU have much earlier intervention for tracheostomy, usually within the first 3 days, 4 days or so, when the patients are after they're intubated, if they have severe COVID. Our practice here at Bellevue has been more traditional in the sense of waiting 10 to 14 days or so, especially if we anticipate that they're going to have a prolonged course in the ICU. And there's some centers across the US that have a longer wait time, that some are waiting 2 weeks, 3 weeks, even 4 weeks until deciding to proceed with a tracheostomy. So that's some of the criteria we use to determine if someone is ready to be transitioned out of the ICU. If they have a tracheostomy and they're stable, then we think that they're more likely to be able to leave the ICU sooner. Obviously, they need to have stable respiratory symptoms. And interestingly for us as well is if they have renal failure, which we've seen a significant portion of these patients have, are they tolerating hemodialysis? Are they on a stable regimen, or are they still acutely sick? So those are the general criteria that we use to determine if a patient's ready to transition from the ICU. Now the question is, where are they going to go from the ICU? You know, the question comes up to having pop-up ICUs or a step-down unit that can manage these patients for a prolonged period of time. But then you have to ask yourself, well, at what point is it safe for those patients now to be transitioned from there to somewhere else, a facility where they can have longer term care, especially if they have a tracheostomy and they're still requiring a ventilator or they're still requiring some sort of support. And so when we're discussing transitions from the ICU, one thing that becomes important is the barriers that exist. So bed capacity is obviously very important. As I mentioned, for us here during our peak, we had over 120 patients that were in the ICU for a traditional 12-bed ICU. We were significantly enlarged, and we had significant different providers that came to help us during this time. But bed capacity became significant because we converted a lot of the other ICUs and a lot of other floors into pop-up ICUs. So that's something that needs to be discussed as well and be understood really well as well. And then, as I mentioned, this prolonged ICU course. Other issues that really come up for these patients when they're being transitioned is, well, the long-term complications for them. So delirium is a very significant issue. A lot of these patients are on heavy sedatives for a prolonged period of time as well. Obviously, if they have a tracheostomy, we can decrease that as needed. Physical therapy and occupational therapy is incredibly important. And initially, during our initial search here, we noticed that it was very difficult to have, for all of these patients to have appropriate therapies involved. So these patients become very, very deconditioned, and this has long-term impacts on their overall outcomes. VTE prophylaxis, and this is a hotly debated topic. I know that's going to be brought up again, and Dr. Mukherjee is going to speak on it another ECHO talk as well. Well, how long do we actually treat these patients with anticoagulants? We've noticed this is, as we've said, patients are at risk for prothrombosis. So do we actually treat them for typical 3 months, 6 months, or longer? We're still collecting all the data. And then the other issues are medications. So what medications these patients end up leaving with? As I mentioned, a lot of these patients, if they have a lot of sedative requirements, if they're being weaned off, we have to monitor them closely, restarting their home medications, restarting their new medications. So those are all things that come into play for us when we're deciding on which patients transitions out of the ICU. And once they're ready to be transitioned out of the ICU, now the question becomes about discharge. Well, really to determine when someone is ready to be discharged, it really depends how stable they are. And the readiness to determine if someone's ready to be discharged is done by the primary team, obviously with discussion with social work, with physical therapy, occupational therapy, obviously with the patient's family, and overall understanding what their patient trajectory is. So it becomes a question of, is the patient safe enough to go home? Or do they need to go to a long-term care facility if they still have complicated issues that need to be addressed? If they're going to be discharged home, some things that are very important for the patients are, well, what isolation information do they need, especially if they're earlier on in their course? Informing the family members about what to do at home, about the household, and isolating and self-monitoring at home. If the patients require oxygen, how to appropriately continue without oxygen and replacement of tubes. So there's a lot of education that's involved. And then obviously physical therapy and occupational therapy, as we said, or nursing care. So those are all important to identify before these patients are ready to be discharged home. And homelessness, unfortunately for us, is an issue as well, in that these patients, are they safe to leave? If they are safe to leave, where are they going to go if they don't have a home? So that's something that needs to be carefully addressed with social work and care managers. But those are the patients that we can say are going to be discharged home. Now, as we've noticed, there's a significant number of patients that are not ready to be discharged home. So that need some sort of long-term care facility. And one of our colleagues are going to speak on to that very shortly. So in order to determine which patients are appropriate for that, we have to determine, well, where exactly will they be going? What type of facility is appropriate for them? Will these facilities have the appropriate capacity to take care of all of these patients? As I said, we've had 1,300 patients discharged from Bellevue. We've had several patients discharged from our ICUs who still had a tracheostomy, who still may have had sedation that they required. And so we have to find an appropriate facility where this can that their care can be transitioned to. Do they need dialysis? That's also an important question. Are the facilities that are available, are they able to provide dialysis if they need that? And are they able to treat their respiratory status that could be varying, can be either improving, or if they're getting worse, what safety tools do they have, safety net is there in place for those patients, and when do they determine if those patients are too critical for the facility? Some facilities also ask retesting, so they want us to retest the patients before we discharge, so that's something important to do as well. Obviously, we don't want to put other patients at risk. And then the question of the long-term follow-up. As I mentioned, these patients have significant long-term complications from their stay, and once they go to a long-term facility as well, they're hopefully going to have a better trajectory and then end up being able to leave those facilities. And then where do they follow up? As I said, we have our clinic here that we see some of these patients as well. But it's an important question to ask, where will these patients safely go afterwards, and who's going to help manage their long-term complications after they leave the hospital and after they leave their long-term care facility? So those are all important questions that we have for the patients that we see as we make a decision to discharge a patient from the acute care setting into either home or very likely a long-term care facility. I know, Rick, you said we're going to avoid questions for a time being, so I'll pass it back to you right now, and then we'll open up for questions a little later. Thank you.
Yeah, Radu, thanks. And
Yep, I'm going to stop the share right now. There we go.
no, appreciate that. Now, so Singh, if you could put your slides up, and as you do that, I'm going to ask one question, Radu, varying from what I thought we were going to do. So I'm fascinated about the pop-up ICU piece, and the reason, and we're doing transitions of care here, but how are you like staffing that? I mean, okay, you might be able to find the beds, but are you staffing that with like ICUs from other units like neurosurgical or something? How are you doing that?
So that's what, so initially, as I said, here what we ended up doing, our 10th floor is all ICU. So there's the critical care, the cardiology unit, there's the neuro unit, the surgical unit. So we had all of those providers assist us as well. And we were helping them as well. And then when we had to leave the ICU floor, these quote unquote pop-up ICUs, I mean, we're staffing them. We were very fortunate that we're able to get providers from outside of the state that came to help us. And from the armed forces as well that came to help us as well. So we had a lot of different providers that were there. We were working closely with them, obviously, on those patients as well. And there's several people from our group as well that work closely with them on managing these patients and asking any questions that they had. But when it got to the point where we had this huge surge of patients where it was beyond the capacity of our staff, we had to rely on additional staff members.
Yeah, thanks, Radu. With that, I'm going to introduce our next speaker, transitioning care over to post-acute and long-term care. Singh Palat, Dr. Palat is with Geriatrics and Internal Medicine, LTC Rehab Consultants, and is Assistant Clinical Professor at the University of Colorado and Associate Clinical Professor, Rocky Vista University, and is representing AMDA, the Society for Post-Acute and Long-Term Care. Welcome, Singh.
Thank you. And thanks, Radu, for bringing up such great points about the transfer. And you're definitely right. When I see a person who's coming out of an acute care setting, my very first question, especially as a physician working in post-acute long-term care, is this person going to the right place? Many of these patients are coming out of the hospital with requiring some management of tracheostomies. Like you said, they might require hemodialysis. They need monitoring for their hemodynamics. Some are still weaning off of oxygen. This slide lists the many, many different places people can go after they are discharged from an acute setting. And each one of these settings is very different in terms of the level of acuity they can provide. From where I work is skilled nursing facility along.
Singh, we lost your audio there. Maybe you can like try again with the audio.
Unheard of. Oh.
You're back.
Oh, okay. I'm sorry. Was I lost?
No, we lost you for about 10 seconds.
Oh, I'm sorry. Okay.
That's
But
okay.
I'm glad
Go
I'm
ahead.
back. Well, I have been asked before, and I think I should just clarify that it is almost unheard of for a long-term care facility to have airborne isolation or negative pressure rooms. When a person is coming to one of our facilities, they'll usually be assigned to a COVID unit if the building is set up for it. Otherwise, they'll probably be assigned to a room with other COVID patients. And there are some facilities that have private rooms. At this time, almost all new admissions will start with a 10 to 14-day isolation period. This means that the staff might don gowns, eye protection, and N95 masks if the facility has access to that sort of PPE. Unfortunately, that's not guaranteed. I can tell you that checking for SARS-CoV-2 right now with PCR, my results in the last month have taken 6 to 8 days to get a turnaround time. And so right now, using testing to determine isolation and other management decisions is simply not practical at all. And depending on the circumstances, visits from family members are still highly restricted. So families can't assume that just because the patient has left the hospital setting, that they can start to visit again. And so unfortunately, that's been a big blow to many of our families. Now, I always try to see my patients within 72 hours of admission. The federal regulations, however, for a skilled nursing facility or a long-term care setting is one physician visit within the first 30 days. And in some rural communities, even meeting that standard can be a struggle. Some practices are turning to telehealth during the pandemic to help. If a patient requires a specialist for follow-up, in most facilities, consults are not available on site. And you're lucky that it looks like in your area, Radu, there's a post-ICU follow-up clinic. And so certainly sending our patients out to a clinic like that, or to pulmonary or to ID to get some follow-up can be helpful, but it does bring up a whole bunch of challenges like communication between the specialist and the facility. And also if the patient leaves the facility for this specialty follow-up, they might have to start over on their 10 to 14 day isolation period. We know that patients recovering from COVID may still have a lot of monitoring necessary for this post-ICU syndrome that you mentioned. They need monitoring for their hypoxemia, treatment for their coughs, management of delirium, and treatment for their deconditioning. They might be taking meds that have to be stopped and weaned, the anticoagulation that you mentioned. They might be on antibiotics for bacterial infections, or they might be weaning a course of steroids. And the patients also need to be treated for their debility, their functional status, nutrition, endurance, and also mental health. And right now, we don't have a lot of data. We don't have any guidelines for the symptoms, medication management, and rehab for the post-COVID patient. And so right now, just as clinicians, we're all just trying to use our best judgment. Without question, certainly before the pandemic and right now, knowing the patient's goals of care for advanced care planning has been very crucial. And it's not just a matter of knowing on the chart if they're full core or DNR. Each patient needs to have a conversation about if they get sick again, whether it's related to COVID or something else, would they want to go back to the hospital? And incidentally, rehospitalization is one of the quality indicators that CMS uses to evaluate the quality of nursing home care and transitions. For me, as a clinician at the bedside, when I'm looking at transfer orders, if I don't see anything dangerous or nothing terribly surprising, if I feel like the care will be seamless coming from the acute to the post-acute care side, then I can feel that that transition is successful. And patients and their families might not have access to all the transfer orders or know anything about quality indicators, but they definitely recognize poor transitions when they happen. So we need to make sure that our families and our patients' expectations are being met. And the AMDA Transitions of Care Committee is always working on trying to create successful transitions. Right now, good practices that physicians and healthcare systems can do to help improve the transitions include using a warm handoff. That means having a conversation about the case. It might even just mean leaving a phone number to facilitate a physician-to-physician conversation. Discharge summaries are very valuable when they contain the relevant information and when they are passed along in a timely manner. And many systems use tools and checklists to facilitate the transfer between facilities. Right now is a great time to make sure that all the tools contain COVID-specific information. Interdisciplinary team members are usually at the forefront of each transfer, so we have to make sure to keep our case managers in the loop. And finally, continuous quality improvement from both the acute and the post-acute care side are very important. Just like we're doing today, having some case review or having some dialogue from members of different settings can really help to identify opportunities for improvement. Thank you.
Singh, thanks very much. I've got one question. If Echo could kind of like get ready with the polling, not quite yet, but one question. So in your role, like locally, clinically, and then also it strikes me you have like a big picture of what's going on out there with your role with AMDA. If there today, if there was one thing that you could unstick that would help with the transitions of care, what would it be to make it easier?
I don't know if this speaks exactly to your question, but I know that recently when we're sending patients from the acute to the post-acute setting, some of the facilities have been demanding like 2 negative COVID tests prior to the transfer. The CDC has definitely made recommendations as of last week to move away from that. And it's created some, delays in transfers, some confusion when test results really aren't consistent with the clinical picture, and with facilities not knowing what to do when they get the results and they weren't as expected. So I think it maybe adhering more to the clinical guidelines and not sticking to, archaic protocols like testing before admissions and things like that. I think that'd be helpful.
Got it. That's very helpful. I mean, that's a very specific point that I could see could be a really big challenge if not addressed. For the remainder of our time, we have a number of polling questions, and I realize there are a number of you in the audience that are first to these clinical rounds. The polling questions that we have that we're going to put up here in just a second, it truly is the opportunity for all of us to learn from each other. So the more that participate, the more we have a real sense of what's going on in the nation, and actually we have some other countries that join us too. So that will really help if you participate, and that sort of like means that the email kind of like go away from that and like focus here, because we got to keep moving through them. There's about 10 or 11, I think, this time. Some of them, unlike some previous rounds, are a little bit complex. It's not a test. Nobody gets graded on the responses, promise you. And also for those who do respond, everybody gets a chance to see these. You're going to see the results in real time, just like, I mean, we're all going to see it in real time. And also we share this with our HHS Healthcare Resilience Work Group as well. And as for those of you that aren't aware, these rounds are recorded, so everybody gets to see these. It's not like these are any deep, dark secret at all. So feel very comfortable. We don't, we de-identify who responds how to each question. So with that, go ahead and put up the first question. After we do the polling, I'm going to ask each of our panelists to please provide comment after we go through the polling on anything that you've seen or heard throughout the round so far. So this is like simply who you are. And when you take a look at these polling questions, usually at the end of each of the polling question, if it's not applicable to you, there's a not applicable or other, or I don't work in that setting. So everybody has the opportunity to respond to these. It's pretty straightforward. Like, this is like, who are you? This is great. About 50% of you have already voted. That's great. The faster you can like jump on these, the quicker we can move on to the next one and then to get to our panelists. All right, 62% of you voted. Wow, that's great. Let's stop there. So everybody I'm not going to read these. There's so many to go through in terms of the discipline, but it's a really wide representation. That's great. Including a wide representation from other. We don't know who you are, but okay. So, all right, next question. All right, for those in skilled nursing facilities, and there's a don't know there because you don't work in skilled nurse facility or you don't know, that's fine. What proportion of your residents who are diagnosed with COVID-19 are being sent to the hospital for care? So what percent, or I'm sorry, what proportion of your residents who are diagnosed with COVID being sent to the hospital? About 54% of you voted. We'll give it another 5 seconds or so. There's a lot of not applicables, which I would expect given the wide range of participants that we have. All right, let's stop there. 57% of you voted. And I'm not going to read these. I'll leave it up for a few seconds for people to see the responses there. Pretty wide range of those that did respond to one of the percentages up there. Really wide range. All right, thank you. Next. Another one related to care for hospitals. What proportion of patients hospitalized for COVID need a skilled nursing facility level of care on discharge? So this is for those of you who are in hospitals. All right, about 5 more seconds. 52% have voted. All right, let's stop there. Pretty wide range, but looks like for those of you that responded to the percentages, 6%, which was the highest response for the percentage, 6% said 50%. Okay, great, thank you. Next. Since July 1st, 2020, so just basically the past month, our organization's experience with transitions of care from acute care to post-acute care has worked well, needs improvement, not working well. A lot of people are voting quickly on this. Well, it's only you get 3 responses, so. We do about 5 more seconds. About 40% of you are voted. My guess is some of you don't have any experience with transitions of care, so I get that. Should have done a not applicable choice there. All right, 5 more seconds and we'll stop. All right, that's good, thanks. Let's see what results are here. 33% said worked well, 62% needs improvement, 5% not working well. Thank you for all of you who participated in that. That's great. All right, next. Now this is working the other direction, okay? Since July 1st, 2020, just the past month, our organization's experience with transitions of care from post-acute care to acute care has worked well, needs improvement, not working well. So you're moving from post-acute care to acute care. We'll give this about 5 more seconds. There's 28% voted, so a lot of you chose not to vote or you don't have any experience with this. So Echo, let's stop there. Worked well, 40%, needs improvement, 58%, not working well, 2%. At least the percentage of not working well is really low. That's really good. All right, next. Okay, now this is about acute care organizations. And down at the bottom, there's a not applicable or something to that effect. So everybody gets a chance to vote, but it's your acute care organization's biggest challenge now. Your biggest challenge. So for those of you who aren't in acute care, the next polling question coming up is for you. So stay tuned. We'll keep this up for another 5 seconds. There are 44% that have voted. See if we can pop that up a little bit. Yeah, 45%. Okay, Echo, let's see our results. I'm not going to go through these one by one, just the ones that like pop out for sure. Fatigue. Is a big one for sure. I see adequate PPE, testing is big ones. All right, thank you and I see nursing shortage too. Yeah, all right, thanks. Next. So this is for post-acute care, okay? Same options, but this is for post-acute care. And the intent behind these polling questions is to make sure everybody's aware of each other's challenges. All right, let's stop there. 39% voted. Looks like testing capability and capacity. The ones with the highest percentage testing capability capacity. And then there's kind of a scattergram from there, but nursing shortage as well. All right, thank you. Next. All right, this one's going to take a little time. Okay, so currently in our region, post-acute care organizations accept transfers from acute care facilities under the following conditions. So in our region, post-acute care organizations accept transfers from acute care facilities under the following conditions and choose all that apply. So it's multiple choice here. Okay. Every time I see this one, I worked on them yesterday. It's like, feels like a board question to me. All right, I'm going to give this another 5 seconds. About 43% of you voted. I know this one takes a little bit longer than some of the other ones. So we got about 45%. Give you another couple of seconds. And let's stop there. And I'll leave these up for a few seconds because they're too long to read, but so everybody has a chance to take a look at them. All right, let's go to the next one. All right, how often do acute and post-acute providers formally review transitions of care together in your system? And you see the wide range there. And there's a don't know response available. So we ought to have everyone like participate in this one, or as many as possible. We'll give this another 5 seconds. This one's pretty straightforward. Okay, Echo, we got 50%. That's good. Great. Pretty broad spectrum, really broad spectrum there. As needed is the most common response for those that did respond. All right, thank you. Next. For acute care facilities, what do you do when you can't discharge a patient to a skilled nursing facility? So it's choose all that apply, so multiple choice. What do you do when you can't discharge a patient to a skilled nursing facility? And as we're getting close to the end of the polling, after the polling, I'd like each of the panelists to please comment or ask questions on anything that you've heard over the past 50 minutes or so during the rounds. So everybody has the benefit of your expertise and knowledge. And Manisha, probably I'm going to start with you first, and then probably Carl from a long-term care perspective. All right, let's stop there. Okay. Most common response, keep in the acute care facility. And then second was search for non-skilled nursing facility alternative. All right, next. In July 2020, what was the most common reason a post-acute care facility was not able to accept a patient from an acute care facility? The most common reason unable to accept a patient for last month. About 40% of you voted. Okay, Echo, let's stop there. Most common was none of the above. Well, I missed that one up, apparently. I didn't get the right options up there, but then 18% was lack of available staff beds. Maybe it was testing, I don't know. Yeah, I didn't have the right options, apparently. Okay, next. Echo, I think that might be the end, right? 11?
Last question.
Yeah, great. Okay, if we could go back to the participant or panelist view, that'd be great. Or I guess I got to close out. All right. So thanks, everyone. I realize there are a number of questions that have popped up and so forth, and maybe I'll try to get to some of those, but I want to make sure that our panelists have the opportunity to comment. So Manisha, please, any questions, comments that you might have for the good of the group based on what you've seen and heard?
All of us here are trying to learn about how to manage COVID that is applicable to acute care and our post-acute care setting. The more we communicate and the more we collaborate and understand each other's problems, the easier it is going to be for all of us and the community and involve our community in this process. This is how we're going to get the result that we're looking for. I would have loved to have an option of all of the above to a lot of these barriers. We have nothing.
Sorry about that.
So it is a difficult situation, and it is a fast-moving situation. The states that were affected, like New Jersey, the regulations could be different from what it looks like somewhere where it is not as rampant. So following your state guidelines as well as your CDC guidelines can be tricky and can be challenging to all of us. So I think that's where, going back to your first question, what can we do better? I think communication is the key. The more we communicate with each other both ways, the better we can help our patients and the better we can help each other through these stressful times where all of us are fatigued and all of us are going through this to a much extended period of time that we want to. So I think that really is the key, is how do we do this together and how do we keep each other posted about the changes that are happening, especially at the rapid rate that they're changing. The recommendations, the testing is the big area where we started out with, we needed 2 negatives, we don't need 2 negatives. Extended period of negative is not infectious anymore. That is what most of our data is suggesting. So helping each other understand and relieving some of these anxiety and stress associated with this illness, I think would help all of us provide better care to our patients.
Thanks, Manisha. Appreciate that. Christian?
Thanks, everybody, for a great discussion today. Really appreciate this. 2 comments. I second the communication that Manisha has already brought up. Other thing is just to understand staffing is also a concern in post-acute long-term care facilities. We have seen once a COVID outbreak occurs in a nursing facility, we have seen up to 50% of the staff pick up and leave. And so understanding that we have a lot of hourly waged folks, minorities, and it has been very, very challenging to deal with staffing in post-acute long-term care. So understand that as a major limitation. The last comment I have is about the question on the poll: how many COVID-19 SNF patients end up being transferred to the hospital? I think it was somewhere around 10 to 20%. I would just second the fact that it mirrors somewhat what is happening in the community. So, you know, upwards of 15 to 20% of COVID patients require acute care. For our nursing facility outbreaks, it's similar to that, somewhere between perhaps a little bit higher, 20 to 30%, but also recognize that post-acute care facilities that are doing this well are incorporating families and patients' choices. So advanced care planning, when you are diagnosed with COVID-19 and you have already severe COPD, end-stage heart failure, being transferred to the hospital may not be in your best interest. So we have tried to push advanced care planning as an important discussion point prior to, upon diagnosis of COVID-19, but also prior to hospitalization. So thank you all for all your comments, and really excellent. Thanks, everyone.
Thanks very much, Christian. Paul?
So I would agree. I mean, I think these were great presentations, and definitely thank you to both of you for all of that. I think, you know, there's so many things that are hard in this space, but one of them is creating a community and trust in the communication. That there are often so many different hospitals that are discharging and so many different facilities that are receiving, that there's really a challenge with coordination of the criteria, as was mentioned, about what kinds of testing are needed for patients to flow. And I think one possibility that may be open to folks is using their healthcare coalitions as a convening entity to try and have both the acute care hospitals and the subacute facilities, the SNFs, communicate. But also it may be helpful, and I know actually several places have tried this, using their health department to come together as an arbiter to kind of try and get people to agree on a common set of rules. Just because, again, if every different hospital has a different practice for how they remove precautions, if every different SNF has a different set of requirements, it's really hard to manage the system efficiently. So just definitely, again, I think great work being done here. There's a lot of great work being done around the country, but one strategy if folks are having a challenge in their area.
Yeah, thank you, Paul. Vikram, and then I'll go to you, Abby, for any comments from your perspective, and then our speakers always get the last word. So, Vikram, and you know, by way of reference, this is like back to the beginning of, I don't know, 6 to 8 weeks ago. We did one on the long haul for these patients. So, particularly interested in hearing your thoughts.
Thanks, Rick, and again, a great job, Radu, and Singh, great to hear your thoughts. One of the few things that we were lucky in New York City and in the Northeast to be is that we were the sole epicenter when we got hit in the spring. And we got a lot of help, nursing help, physician help from many other parts of the country. I don't know if that will carry forth when Texas and Florida and Arizona and California are being hit hard. So nursing staffing, physician staffing is going to make ICUs and acute care extremely challenging. And to make sure that there are ICUs that are able to accept critically ill patients, the flow of patients from acute care to a post-acute care facility has to be as seamless and as easy as possible. Which goes back to Manisha's points that coordination and a symbiotic relationship is key. And removing all the barriers of excessive testing, of unnecessary not following CDC guidelines have to be obliterated very early so that the ICUs can take patients. Because if the ICUs are full and don't have space, it is going to be a horrible catastrophe, as parts of Texas are already seeing. So I think the flow of patients from an ICU, from an acute care to a long-term, to a post-acute care has to be as seamless, taking care of all the bureaucratic nightmares that come in between. Thanks, Ray.
Thanks, Vikram. Abby, any comments?
Sorry, no, and I'll be honest, my internet keeps going in and out today. It's one of those days. I said no, and then clearly I have a comment. I think, what's really struck me is that the need for partnership here, and the importance of partnerships to facilitate these transitions. And I think we often, as groups, we work within our stovepipes. So we talk amongst acute care folks, we talk among post-acute care folks. And so one of the things we were hoping to accomplish today is to facilitate these cross-system dialogues. And I would be interested from people who have joined, are there, how are they working with their partners in acute care or post-acute care to make these transitions work? So I think as people leave today, how do they better connect with their partners on the opposite side is something that we're hoping this can sort of fuel and also lead to a greater dialogue.
Thanks, Abby. And I shared your hope we would try to build some bridges here. And it's not like the bridges aren't there. The bridges are there. But I also, I think one of the real challenges is everybody's just trying to stay afloat. I mean, there's the fatigue factor you saw there and so forth. So the energy, while it's like, is there any energy left? This clearly is worth spending the energy on. Because I mean, Vikram, you hit the nail on the head. It's like the flow piece. It's like the EMS piece. It's like the emergency department. It's the critical care. And one of the things, when we started rounds, we started on pressure points. But indeed, long-term care is another one of those huge pressure points. And finally, we're starting to work on connecting the dots with the rounds. And hopefully, this helps stimulate local connectivity. And Abby, just want to shout out and appreciate your collaboration and working together on trying to build these bridges with these communities. Appreciate that. So last word, Radu, and then Singh, and then we'll close out. And again, there are tons of questions. A lot have been answered in the chat, or I think some have been answered, and some are very unanswered. And yet hopefully it stimulates people to work on some problem solving. So Radu.
Well, just briefly, I mean, I have to echo what everyone's been saying. I think we're at an interesting time point right now. We're essentially learning as we go, and we're learning all these long-term impact that these patients are having, and this communication key is so incredibly important, as you mentioned. And you know, the experience that we had here in New York is not going to be the same everywhere else throughout the country, because everything's changed. As Vikram has said, we were the sole epicenter, and now all of a sudden you have all of these different hotspots. And as the hospitals become overloaded, as they will, because there's going to be a significant number of cases, having this stabilized flow is going to be so critical. So this communication piece with the centers before this happened. So if there's other hospitals on board who aren't incredibly busy yet, establishing a better communication, establishing protocols is so key right now to actually have a good workflow of patients and transition of care. So I think, you know, this is the beginning, unfortunately, and we're learning as we're going, but I think other centers can learn from all of these experiences that we've had.
Thanks, Radu. Singh.
Well, thank you for having us here. I think sometimes as post-acute physicians, we feel like we're either left out of the conversation or not considered valuable enough to be part of it. So thank you for talking about transitions today. And you talked about having enough energy to work on things. The building where I was just recently the medical director, we have a capacity for 90 beds. Over the summer, almost 70 people have tested positive for COVID-19. 24 people have died, all of them patients that I had taken care of for years. It's been very time and emotionally intensive for all of us. And I think that having dialogue like this is great. If we could have another echo session, either looking at some data from post-acute recoveries and long-term care, or looking at the transition from the long-term care setting over to an ER or over to a hospital, I think we would also learn a lot.
Thanks for the suggestion. With that, I got to tell you, it was a new adventure, having two disciplines who are so connected, but sometimes really apart, like physically. And you know, I frequently I've thought about like really, you know, my conversations with long-term care in the emergency department, and this was not in a pandemic, was when I picked up the phone and I needed to transfer a patient. The proactive conversations are rare indeed. And, you know, as I mentioned, I think this is worth spending the energy on proactively, and appreciate those points for sure. Thanks to our participants, you were great. And it's like so much happened in the chat, so much happened in the Q questions, and hopefully at least some of them got answered. And yes, I know many didn't go answered, and I feel badly about that. But as many have said, like, well, you know, an hour is probably not enough, but then you can't do 2 hours, and really 45 minutes because I have a 1 o'clock meeting. So there's no perfect answer to this. We try the best we can and appreciate everybody's patience with it. Really appreciate your participation in the polls. It helps everybody learn, and in the chat and the QA. And for our panelists, thanks very much for being on, taking out of your busy schedules in the middle of a pandemic. It's really important. Abby, thanks for being a great partner with this. Echo, always wonderful. And to our speakers, Radu and Singh, really, really deeply appreciate your contribution to this dialogue. And Singh, I think you're right. I mean, it's like, at least we got this far with this, and can we keep the dialogue going in a proactive way? When everybody's really dragging, we got to like work on making sure we spend energy on this too. So thanks everyone, and we'll see you on the next one. Bye.